Thank you very much. Very pleased to be here and honored to be kicking off this session talking about specifically the impact of critical illness on long-term outcomes. I should just mention I don't really have any conflicts. I'm an associate editor at the Blue Journal, and I do have some research funding for related work from Canadian Institutes of Health Research. So really the questions that I want to try to get at today are, what is the true burden of what I'm going to call the post-intensive care syndrome? And for those of you not familiar with that term, I'll show it to you in a moment. And then I think most importantly, how much is due to critical illness? And to show you how we have to be kind of careful with the literature in terms of interpreting, because of course we want to know ultimately what we can do to help people to know that what we're helping them with is related to what's happened to them in the ICU. So a number of years ago, we published a paper that looked specifically at long-term survivorship after severe sepsis in older Americans. This was using Medicare data in the United States, which covers most of US people over the age of 65. And what we found was that severe sepsis incidence, not surprising to any of you, is increasing really markedly compared to acute myocardial infarction, which is that dark, green line there is AMI incidence, and not surprisingly, again, the funding has increased, or not funding, the spending on patients has increased with the incidence going up. And of course, with incidence going up, we also have a lot more survivors, and we're seeing this uptick in 3- and 5-year survivors of severe sepsis. And so this is not true, of course, just for severe sepsis, but for many of our diseases in the ICU where we're seeing a lot of survivors. I was part of a task force in 2012 at the Society of Critical Care Medicine that was actually led by Dale Needham on this paper, who has been here at this conference, where we tried to figure out how do we talk to people about their long-term outcomes after critical illness. And we came up with the idea of post-intensive care syndrome. Now, not everybody likes this term because they worry that it gives this idea that to have the syndrome, you must have all of these things: mental health problems, cognitive impairment, and physical impairment. And the idea was not so much that, but to recognize that some people will have some, or if not all, of these problems, and we needed a way to communicate with patients, families, and also healthcare providers outside of the ICU with regard to what are the things that we should be worried about in our patients. And what are these problems? Well, this is just a kind of quick list of many of the ones that are published upon: fatigue, weakness, foot drop, PTSD, depression, anxiety, sleep disorders, cognitive impairment, dementia. They're all things that have been studied in detail in and of themselves. As an example of some of the early work that really highlighted the concern that many of our patients were experiencing problems, this is one of the earlier papers by Ramona Hopkins that came out now back in 2005, so over 10 years ago, looking at ARDS survivors. And this graph shows you on the top line there kind of normal controls, and at 2 years across a whole bunch of domains that were measured in terms of physical and psychological function, that at the 2-year mark, these survivors were not similar to the general population controls, that they hadn't made it back to their sort of peers' baseline. Now, I think that we have to be very careful with data like that. It was a very important starting point to get our attention and recognize that we needed to look at this. But I want to point out that a lot of these early studies in particular are mostly smaller cohort studies, and they're often very high-risk, extreme groups of patients. And we also have to be careful that we're not attributing the outcomes to critical illness erroneously, because there's other factors at play here, including chronic disease and also hospitalization. So as an example of sort of how kind of extreme this group is in terms of the patients, there's certainly patients we think of as critically ill, but they're not all ICU patients. This is, again, data from the US looking at everybody over the age of 65 in Medicare. And all we did was quantify how long patients were in the ICU in the United States. And those gray bars show you what percentage of ICU patients are there more than, say, 7, 14, or 21 days. And the black line is showing you what percentage of bed days they represent. So why do we remember them and think about them? Well, it's a standard cognitive bias. You remember the patients you're seeing day after day, and you forget about all the ones who are cycling through. So the patients that are studied in these ARDS cohorts are certainly important, but we can't extrapolate and say this is therefore true for all ICU survivors. This is true for those severely ill ARDS survivors. The other thing that's very important, this is my absolute favorite title of any paper ever published, hospitalization-associated disability. She was probably able to ambulate, but I'm not sure. And I think we've all been at the bedside when all of a sudden there's this pause, and we're talking about whether or not they're going to get out of bed that day, and someone says, well, could they walk before they came in? And everybody kind of looks at each other, and then you start flipping through the chart, and you're trying to figure out what was this person's baseline. And of course, you're not going to get them back to being someone who walks if they weren't someone who walked when they came in, or it's very unlikely unless they're having something like back surgery, right? So I think it's very important that we don't attribute something that's happening we don't attribute long-term outcomes to the ICU when people are coming in with this sort of disability. A great example of this is work by Jack Awashina out of Michigan, where he was looking at a cohort of elderly individuals in the United States where they had every 2 years a sort of psychological assessment and physical assessment, and he followed patients through their severe sepsis episodes with hospitalization. And he was looking at depression after severe sepsis in this cohort, and it's pretty high. You can see it's almost 30% of individuals with after severe sepsis have depression. And so, of course, if you don't know anything about these patients beforehand, you're going to say that critical illness with severe sepsis is causing 30% of patients to develop depression. Well, it looks a lot less impressive when you actually see the before data. Now, there is an uptick. It's a real uptick, and so I don't want to diminish that, but it's only about a 5% increase, not a 30% increase in depression that's going on here. It's also important to recognize that a lot of the things we worry about are not unique to ICU patients, that there are things that are unique to hospitalized patients that other people are thinking about. In that sense, it's important we don't reinvent the wheel. Harlan Krumholtz at Yale published this back in 2013 about post-hospital syndrome, an acquired transient condition of generalized risk. So it's recognized that just patients being in the hospital alone is increasing their risk of some of these same problems. And this is evident in work we did where we looked in Denmark at the risk for a new psychiatric diagnosis after critical illness. And so that bottom line there in black is the general population controls. That top line in red is the increased risk of having a new diagnosis of a psychiatric disease, a real increase uptick there after critical illness. But the blue line in the middle is hospitalized patients who we use as controls. And so you can see it is real, but it's a bit less impressive than if you took that blue line out and only saw the ICU patients in comparison to the general population. Some work that's come out recently from Scotland has highlighted what is the impact of comorbidities in terms of long-term outcomes for our patients. They had the benefit of a registry of all patients admitted to the intensive care unit in Scotland, and they followed them. And on the y-axis here is actually hospital costs per year, so a measure of hospital resource utilization in the years following critical illness. And you can see here that for those who had one or more comorbidities, the use of healthcare resources after critical illness was the same as those controls who are, sorry, they're not population controls, those are hospital controls. So they look exactly like patients who've been in the hospital without critical illness. But you can see for those who have comorbidity, no comorbidity, those are the patients where we see a signal for an increase in resource utilization after critical illness. Similarly, we looked at diagnoses of dementia in those over the age of 65 in the US, looking at a comparison, again, in this case, with general population controls. And there is certainly an increased risk of a diagnosis of dementia after critical illness. So this is following patients out for 3 years. And you can see the hazard ratio is 1.6, so it is relatively impressive looking. But of course, there's a lot of people there who in the general population who are getting diagnoses of dementia. And in fact, the absolute risk, although real, is again maybe smaller than you might imagine if you just saw that hazard ratio of 1.6. So again, a real effect clearly related to the critical illness, but not that large. Finally, there's what I call the age paradox in critical illness, in that fewer younger people get critically ill. The majority of our patients are elderly. They overall have a better chance of recovery if they're younger, but they definitely seem to have the greater impact, like those who have no comorbidities. In this same paper from Scotland, what they showed was that if you were over the age of 70, and for those of you nearing 70, you can say, you're still in the young category if you're less than 70, according to the Scots here. But if you were over 70, there was no difference in resource utilization whether or not you were in the ICU or just in the hospital. But for those younger than 70, again, you see this signal of the increased resource utilization having been in intensive care. And it makes sense if you think about, a 25-year-old trauma patient who's gone through a time in the intensive care unit, relative to their peers, they may absolutely be experiencing unexpected hospitalizations and such in that year or two following critical illness. If you have an 80-year-old who's got COPD, who has an exacerbation that ends up in the ICU, they're probably going to look more like their peers. It sort of feels like that fits. And then finally, I think that we do have to recognize, therefore, that there's some real groups here that are at very high risk. And I think the work by Margaret Herridge out of Toronto, this is her original cohort of ARDS survivors that she published in the New England Journal back in 2003, really focused on a very young cohort of ARDS survivors with high severity of illness and long length of stay. But what this is showing you is the percentage that return to work at 1 year. And it's a sort of astonishing 49%. Half of the people who had ARDS were not returning to work. In fact, I think she's followed it out now to 5 years, showing that this continues. And so certainly, again, for these young patients, that's where the signal is. And I think that this is an important signal from a societal perspective, certainly in terms of people's ability to be back as part of society in the community. And there's going to be, I think, a real renewed interest in sort of the economic consequences for patients and their families with regard to critical illness and what that's doing for the working population. So in conclusion, PICS is real for many individual patients, and I don't want you to take away from this talk the idea that I'm diminishing the experience of these individuals who really are having some or many of these symptoms and problems, but the impact is heterogeneous and doesn't impact everyone. I think we need to be careful in assuming a problem was related to the time spent in intensive care and not be so quick to assume that this is related to the experience of being in the ICU or the actual critical illness, but to be circumspect and try to figure out, therefore, how can we target the patients who really truly are at risk, because they are definitely there, but we need to expend our time and energy and resources on identifying them better so that we can help the ones who need help and maybe not expend resources on those who are either totally fine after ICU saying, what's the problem? I have no issues, or where we're really better off sending them perhaps back to their cardiologist because they've got severe congestive heart failure, or their pulmonologist because they've got severe COPD, and that's what's driving a lot of their debilitation and difficulties after the ICU. And whenever I talk about long-term outcomes, I do like to end with this picture. It's something I actually share with my residents when I'm on rounds with them. This was by Gary Black, who is a survivor of septic shock, and he actually has an organization, which is a kind of patient advocacy group in the US for patients who have experienced septic shock. And he's an artist, and he published a book about his experience, and this is a drawing he did when he left the ICU and was discharged home about how he felt. And I think it's an incredibly powerful image in terms of reminding us that for many of our survivors, there is a difficulty picking up the pieces of their life, and that they do go through a lot of trauma and need help with that recovery. So I'll stop there. Thank you very much.